Welcome to the Deep Dive, the show where we cut through the noise and get straight to the crucial insights you need to be truly well informed. Today, we're embarking on an in depth exploration of an injury that, well, while sometimes overlooked, carries significant clinical weight: Hamate fractures. For us as medical professionals, particularly those navigating the complexities of orthopedics and sports medicine, these are far more than just a niche topic. They're often misunderstood, prone to delayed diagnosis, and can have profound impacts on our patients, especially active individuals. Our mission in this deep dive is to move beyond the foundational textbook knowledge. We're going to extract those really critical insights, the surprising facts, and the practical nuances that'll ensure you're well equipped to recognize and confidently manage these quite complex injuries in your practice. And I'm delighted to say that joining me once again is Professor Mo Imam, whose exceptional ability to synthesize intricate medical evidence and provide broader clinical context makes him the absolute perfect guide for this journey. Professor, it's quite remarkable, isn't it? How such a small bone, the hamate, can lead to such a disproportionate impact when fractured, particularly within the athletic population. And the challenge of delayed diagnosis is just pervasive. It's a real clinical headache, isn't it?
Absolutely. It truly is a classic example of how intricate, often unassuming anatomy can lead to significant and debilitating clinical challenges. And you're spot on about the delayed diagnosis.
Yeah.
It's a pervasive problem that underpins many of the long-term complications we see. That's precisely why a thorough understanding from the fundamental anatomy right through to advanced imaging and management is paramount for optimizing our patients' outcomes.
Right then, let's unpack this. Before we even delve into the fractures themselves, perhaps we should start by really grounding ourselves in the anatomy of the hamate bone. It's a fascinating structure, especially considering its compact size, isn't it? What makes it so unique in the wrist?
It genuinely is unique. The hamate bone holds a really pivotal position within the carpus. It's one of the 8 carpal bones, specifically located on the ulnar side of the discal carpal row. Imagine it as a key component in the architecture of the wrist, a sort of wedge-shaped block that's central to both wrist and hand function. It doesn't just sit there in isolation, it articulates with several crucial neighbors. Radially, meeting towards the thumb side, it connects with the capitate. Proximally, it forms a joint with the triquetrum. And then distally, it creates critical articulations with the bases of the 4th and 5th metacarpals. So it's deeply integrated into the wrist's biomechanical chain, linking the forearm to the ring and little fingers.
And it's not just its position, is it? It's got this very distinctive feature.
Precisely. What truly sets the hamate apart, and what makes it so clinically relevant in these fracture discussions, is its distinctive protrusion, the hook of the hamate. It's also known by its Latin name, the hamulus ossis hamati. This is a very characteristic long and relatively thin osseous prominence that extends palmarly, that is, towards the palm from the main body of the bone. To give you an idea of its size, on average, it's about 1.3 centimeters in length, 1.0 centimeter in width, and roughly 0.5 centimeters in thickness. So it is indeed a small, almost delicate projection. But this seemingly small projection plays an absolutely crucial biomechanical role. It acts as an essential attachment point for several vital ligaments, including the transverse carpal ligament, which forms the roof of the carpal tunnel, and the pisohamate ligament. These attachments are fundamental for wrist stability and function. Furthermore, it provides the origin for important muscles, specifically those of the hypothenar eminence, the opponent's digiti minimi and the flexor digiti minimi, as well as parts of the flexor carpi ulnaris. These muscles are essential for fine motor control and powerful gripping actions. Beyond these direct attachments, the hook also functions as a vital pulley for the ulnar flexor tendons, guiding their path as they traverse the wrist. This pulley movementism is critical for the efficient function of the tendons that flex your ring and little fingers.
I see. So it's doing a lot of work for its size.
A tremendous amount. Now, from a developmental perspective, it's also quite interesting. The body of the hamate ossifies, meaning it forms bone, during the first year of life. However, the hook develops from a separate ossification center. It typically fuses with the main body between the ages of 12 and 15 years. This developmental process can sometimes lead to anatomical variations that are incredibly clinically relevant. For instance, if this fusion fails to occur, the hook can persist as a secondary ossicle, which we call a bipartite hamate, or os hamuli proprium. Other variations include hypoplastic hooks, where the hook is underdeveloped, or in rare cases, even complete hookaplasia, meaning it's simply absent. Research has shown that these variations are not entirely uncommon. For instance, a large review of hand radiographs identified such variations in nearly 100 cases out of over 3,000, highlighting that these aren't just academic curiosities. They absolutely need to be considered in clinical diagnosis and interpretation of imaging.
That's a truly remarkable level of detail for such a seemingly minor anatomical structure.
Yeah.
It really brings home just how intricate the wrist's biomechanics are. So, Professor, with that anatomical foundation, when we talk about Hamate fractures, how are they typically categorized in clinical practice? And what's the most important distinction we need to make?
The most important distinction clinically is to primarily classify hamate fractures into two broad patterns: hook fractures and body fractures. The Milk classification is a common and widely used framework here, which quite simply differentiates them. Type I refers to hook fractures, and the Type II refers to body fractures. While the Milk classification provides a good initial distinction, helping us conceptualize the injury, it's worth noting that more detailed classifications exist for body fractures. For instance, a classification by Garcia Elias subdivides body fractures into sagittal oblique, dorsal coronal, proximal pole, and medial tuberosity fractures. These subcategories can be useful for understanding specific mechanisms of injury and their potential implications, particularly in complex trauma. However, the most frequent clinical scenario we encounter, and indeed the one we'll focus on heavily, relates to hook fractures. They're generally much more common, accounting for approximately 2 to 4% of all carpal fractures. This prevalence, coupled with the hook's unique anatomical location and the diagnostic challenges it presents, truly makes hook fractures a significant focus in day-to-day clinical practice.
Okay, here's where it gets really interesting and frankly crucial for many of our listeners working with active populations. You mentioned these fractures are notably prevalent in athletes. What specific activities or forces put the hamate at such significant risk? Is it simply a matter of direct impact, or are there more subtle biomechanical factors at play?
That's a superb question because it's not just brute force, it's often a combination of factors. The athletic population, particularly those involved in gripping sports, are indeed at a heightened risk, and the biomechanics behind it are fascinating. The primary causes of hamate fractures are typically direct impact and repetitive microtrauma. From a biomechanical standpoint, the hamate hook is inherently vulnerable. It sits right under the hypothenar eminence, that fleshy part of your palm below the little finger. It's exposed to compressive forces when the palm is struck directly, but also to significant shear forces exerted by adjacent flexor tendons during forceful wrist torque. Think of it as being caught between a rock and a hard place. Direct pressure from outside and dynamic forces from within.
Right, a sort of pincer effect almost.
Precisely. Let's consider some concrete examples from various sports, as this really brings the mechanism to life. For golfers, these fractures almost invariably involve the non-dominant hand. The classic mechanism is forcefully grounding the club, especially striking a hard object like a rock or a deeply embedded root. This translates into a direct high-impact force being transferred right through the grip of the club into the hook of the hamate. It's a sudden, sharp jolt.
Ouch, you can almost feel it.
Indeed. For baseball or softball players, the injury is sustained from a similar blend of factors. Gripping the bat incredibly tightly, particularly during a powerful swing, or during the action of checking the bat, which involves quickly stopping its momentum. Direct impact, such as being hit by a pitch while holding the bat, can also cause it. Studies have actually highlighted this specificity, indicating that nearly all, around 97% of baseball players and every single golfer, 100%, with swing-related injuries, sustain these fractures to their non-dominant wrist. This strong correlation speaks volumes about the mechanism.
Wow, that's quite specific.
It is. Racket sports, such as tennis, squash, and even stick sports like field hockey or ice hockey, also contribute a significant number of cases. Here, it's often due to repetitive trauma from the racket or stick handle, constantly impacting or hammering against the hypothenar eminence during powerful strokes or shots.
So it's not just the singular high-energy impact, but the constant subthreshold stresses that can accumulate over time. That's a critical distinction. And we've seen instances of stress fractures in the literature, for example, in athletes from intensive climbing and even repetitive military-style push-ups. Can you elaborate on how these microtraumas lead to fracture? Is it just about overload, or is there something specific about the hamate's bone biology that contributes to this?
That's a brilliant point, and it moves us beyond the acute trauma. Stress fractures truly highlight the cumulative effect of repeated stress impaction on the hypothenar eminence. Unlike acute traumatic fractures, which happen in a single, sudden event, these develop over time due to repeated microtrauma. Imagine the hamate hook being repeatedly compressed or subjected to high shear forces with every push-up, every hand jam in climbing, or every powerful serve in tennis. The bone tries to remodel and adapt, but if the rate of microdamage exceeds the rate of repair, you get a progressive breakdown of the bone's microarchitecture, eventually leading to a full stress fracture.
It's a fatigue failure of the bone.
A bit like bending a paperclip back and forth until it snaps.
Exactly. Very good analogy. For instance, a very interesting case reported detailed a stress fracture in a climber. This wasn't an acute fall, but rather a cumulative injury from the specific demands of climbing. They managed it successfully with cast immobilization, and subsequent CT imaging confirmed bony consolidation. Similarly, other researchers documented successful treatment in a professional tennis player who developed a hamate stress fracture, again from repetitive athletic activity, successfully managed with 6 weeks of cast immobilization. This mechanism also brings into sharp focus a critical aspect of the hamate's bone biology, its vascularity. The hook of the hamate has a relatively tenuous blood supply, particularly at its base. When you have repeated microtrauma, this can compromise that already limited blood supply, making the bone more susceptible not just to fracture but also to non-union, even with these stress-induced injuries. The constant subthreshold impacts can effectively disrupt the microcirculation, hindering the bone's natural healing capacity. So it's a double-edged sword. The repetitive stress causes the initial damage, and the compromised blood supply can then hinder its repair.
So, what does this all mean for us in the clinic? Given these varied mechanisms and the anatomical vulnerability, what should medical professionals be looking for in a patient presentation? And crucially, why is this particular fracture so notoriously difficult to diagnose? Is there a red flag that screams Hamate fracture when you're in a busy clinic?
This is indeed where the rubber meets the road, because the clinical presentation can be quite subtle and, as you rightly highlighted, easily mistaken for less severe or more common conditions. For hook fractures, the typical symptoms often revolve around pain. It's usually persistent and localized to the hypothenar area, specifically on the ulnar side of the palm, just distal to the wrist crease. A key characteristic is that this pain is almost invariably aggravated by activities requiring forceful gripping, pushing, or pulling. Patients might also complain of pain with dorsal ulnar deviation of the wrist. Occasionally, they might even report feeling a deep, nagging pain dorsally on the back of the wrist, which can be quite misleading.
Making you think it's something else entirely.
Exactly. Beyond pain, a classic presentation is significantly weakened grip strength. Patients will often report a noticeable reduction in their power grip, impacting their ability to perform daily tasks or athletic activities effectively. This is particularly debilitating for athletes. Neuropathy is another common and often underrecognized finding, with hook fractures, with ulnar nerve symptoms occurring in a significant proportion, sometimes as high as 20% of cases in clinical series. You might observe paresthesias, that's the pins and needles sensation in the ulnar distribution, affecting the ring and small fingers. Or, perhaps more subtly, isolated motor weakness, particularly in the intrinsic muscles of the hand supplied by the deep motor branch of the ulnar nerve. While less common, median nerve dysfunction, leading to symptoms of carpal tunnel syndrome, has also been reported in some instances, often in cases with greater swelling or displacement. Other nonspecific signs which make diagnosis harder can include generalized swelling, some bruising, stiffness, or a limited range of motion in the wrist.
So quite a vague picture, potentially.
Very much so. Now, when it comes to specific provocative tests in the clinic, direct tenderness over the hook of Hamate is a highly sensitive finding, around 80% sensitive. You really have to get your finger in there, just distal to the pisiform bone, to elicit that localized pain. Another key test, often called the hook of Hamate pull test, involves eliciting pain with resisted little finger flexion. This test has about 70% sensitivity. The rationale here is that the flexor tendons of the ring and little fingers pass very close to the hook, and when they contract forcefully, they exert deforming forces on the fracture site, causing pain. Pain with axial loading of the fourth and fifth metacarpals can also be indicative, suggesting involvement of the hamate metacarpal articulation.
Okay, those are helpful tests to bear in mind.
They are. Now, to address your crucial question, why is diagnosis so challenging, particularly for hook fractures? The primary reason is that the clinical findings can be quite vague and nonspecific, leading to symptoms being frequently mistaken for a simple wrist sprain, a tendinitis, or even nonspecific wrist pain. This often results in significant diagnostic delays. Research has reported a concerning mean diagnostic delay of nearly 6 months, with a staggering proportion of patients, sometimes over 80%, having attended other physicians or clinics before a correct diagnosis was finally made.
6 months? That's really quite shocking.
It is alarming. Imagine the patient frustration and indeed the clinical challenge when patients present with chronic symptoms after months of misdiagnosis. The implications of such delayed diagnoses are quite severe, significantly increasing the risk of serious complications like chronic non-union where the bone simply doesn't heal, and, critically, flexor tendon rupture, which can be devastating for hand function. It's a huge pitfall we must avoid.
That statistic on delayed diagnosis is quite frankly alarming. It highlights a huge blind spot in our collective clinical approach. So, Professor, given these diagnostic challenges, particularly with the hook, what are the optimal imaging strategies that healthcare professionals should employ to confidently identify a hamate fracture and avoid that diagnostic delay? Are plain radiographs completely useless, or do they still have a role?
That's a truly crucial point, especially given the high rate of misdiagnosis. While plain radiographs are typically our initial go-to modality for any wrist injury, they come with significant limitations, especially for hook fractures. Standard posterior anterior PA and lateral views of the wrist have a very low sensitivity for hook fractures, often reported at around 10%.
Only 10%. That's incredibly low.
It really is. The reason for this is purely anatomical. There is considerable overlap of the hook with the main body of the hamate and surrounding carpal bones on these standard projections, making it incredibly difficult to visualize a fracture line clearly. You might occasionally spot subtle findings, such as a disruption of the ring sign. For those unfamiliar, the ring sign is that distinct, bony ring normally seen on the PA view, created by the hook's overlap, and its disruption can suggest a fracture. Other subtle signs include a loss of cortical density at the base of the hook, or even, in very rare cases, the complete absence of the hook's shadow if it's displaced.
So you really need to be looking very carefully, and even then.
Exactly. So due to these severe limitations, when clinical suspicion for a hamate fracture remains high, perhaps you have that athlete with persistent hypothenar pain, and weak grip specialized radiographic views are absolutely necessary. The carpal tunnel view, often referred to as Hart and Gainer's method, is considered the most useful special view. It's designed to depict the hook axially, essentially looking right down its barrel. This can increase the sensitivity to about 40%.
Better, but still not perfect.
No, not perfect. And there's a practical challenge. It requires maximal wrist dorsiflexion, which can be excruciatingly difficult and painful for an acutely injured patient. Other helpful specialized views include a supinated oblique view with wrist dorsiflexion and maximal radial deviation, typically at a 45-degree angle, and modified lateral projections, such as a 30-degree tilted lateral with thumb palmar abduction. It's an important distinction that body fractures of the hamate are generally more readily apparent on routine radiographs than the elusive hook fractures, given their larger size and less complex overlying anatomy.
So it sounds like if our clinical suspicion is high, we really need to push beyond the standard X-rays. What's the next step then in terms of imaging when we're trying to definitively confirm a hamate fracture?
Precisely. Given the inherent limitations of plain films, computed tomography, or CT, scanning is widely considered the radiological modality of choice for definitive diagnosis of both hook fractures and non-union. It offers exceptional sensitivity for detection, often cited at 100%.
100%. Okay, now we're talking.
Yes. A CT scan provides incredibly detailed cross-sectional information on fracture location, its precise displacement, and any comminution, meaning how many fragments there are. This level of detail is invaluable, not just for diagnosis, but crucially for preoperative planning. High-resolution scans, particularly when performed with a specific technique like positioning both wrists and extension against each other in a praying position for side-to-side comparison, have been reported to achieve astonishing diagnostic accuracy: 100% sensitivity, 98.4% specificity, and 97.2% accuracy for acute fractures. It's truly the workhorse for confirming these injuries.
Right, so CT is really the gold standard for the bone itself.
For visualizing the bone detail, absolutely. And then we have magnetic resonance imaging, or MRI. This is arguably the most accurate method of diagnosis in cases of high clinical suspicion, also boasting 100% sensitivity. Its unique advantage, however, lies beyond just bone detail. MRI excels at evaluating soft tissue integrity. This is vital because, as we discussed, conditions like ulnar nerve involvement or flexor tendon irritation are common with hamate fractures. MRI can clearly visualize the ulnar nerve within Guyon's canal and assess the flexor tendons for signs of inflammation or early attritional changes. Furthermore, and this is a critical point for surgical planning, MRI is indispensable for assessing the vascularity of a hook fragment. Knowing if the fragment has a good blood supply is paramount before considering open reduction and internal fixation, as a vascularity would absolutely contraindicate such a procedure due to the high risk of non-union or osteoantrochosis.
That makes sense. You need to know if the bone you're trying to fix is actually alive, essentially.
Precisely. It's crucial information for deciding between fixation and excision.
If we connect all of this to the bigger picture, Professor, beyond the fracture itself, what are the critical associated injuries and potential long-term complications that medical professionals simply must consider when a Hamate fracture is suspected or confirmed? It sounds like the fracture itself might just be the tip of a very complex iceberg.
You've hit the nail on the head. The fracture itself is often just the beginning. The Hamate's close anatomical relationships within the carpal tunnel and Guillen's canal mean that these fractures are very rarely isolated incidents. They often come with a cascade of associated injuries and can lead to significant long-term complications if not diagnosed and managed appropriately. Let's start with soft tissue injuries, which are perhaps the most concerning. Flexor tendon rupture is a significant and quite debilitating complication. This particularly involves the flexor tendons to the ring and small fingers, with an incidence reported between 15% and 17% in some series.
15 to 17%, that's quite high.
It is disturbingly high. These ruptures are often attritional in nature, meaning they occur gradually due to chronic irritation from the jagged, unhealed fracture edges of the hook. This constant rubbing can wear away the tendon, leading to segmental tissue loss. This attritional process frequently precludes primary repair, making reconstruction far more complex, often requiring procedures such as endoside repair or tendon grafting. What's truly crucial and frankly alarming is that these ruptures can occur before the Hamate fracture is even correctly diagnosed.
Oh, goodness. So the secondary complication presents first.
In some cases, yes. Imagine the patient who comes in with a sudden inability to flex their finger, and only then is the underlying chronic Hamate non-union discovered. Less common, but still possible, is ulnar artery thrombosis, sometimes manifesting as Hypothian or Hammer syndrome, which can cause ischemic symptoms in the hand.
That's a truly sobering thought. The idea that the primary injury might be missed, leading to a much more complex secondary problem. What about nerve involvement? You mentioned neuropathy earlier.
Absolutely. Neuropathies are another common concern. Ulnar nerve compression is a frequent finding with hook fractures due to the nerve's intimate proximity within Guillen's canal. Patients may present with classic paresthesias, tingling, and numbness in the ulnar distribution, affecting the ring and small fingers, or, perhaps more subtly, with isolated motor weakness affecting the intrinsic muscles of the hand, leading to issues with pinch or grip. While less common, median nerve compression resulting in carpal tunnel syndrome symptoms has also been reported in severe cases, particularly with significant displacement of the hamate fragments or major associated swelling, as seen in some crush injuries.
So you could have symptoms mimicking carpal tunnel, but the root cause is the hemi.
You could, yes. It's less common, but it happens. Then there's non-union. This is a well-known high-risk complication for hook fractures, especially when conservative treatment is initially pursued. Reported rates for non-union are shockingly high, sometimes reaching up to 50%.
50%? Wow.
Yes, up to half. The underlying reasons are primarily twofold. Firstly, a diminished vascular supply to the hook fragment studies have shown a significant risk of avascularity at the base of the hook. Secondly, persistent biomechanical factors, such as the constant deforming forces exerted by the attached ligaments and tendons, which make it difficult for the fracture fragments to stay still and heal. We also need to be aware of symptomatic partial union as a distinct entity, where healing occurs along the ulnar column but not radially, causing persistent pain despite some degree of radiological union. These patients will often continue to report pain during gripping activities despite initial supportive care.
Right, so even if it looks partially healed, it can still be causing problems.
Definitely. Furthermore, associated hand injuries are unfortunately not uncommon. These can include carpal metacarpal joint dislocations, particularly involving the 4th and 5th CMC joints, which are frequently seen with body fractures, as these articulations are directly affected by the Hamate body. We also encounter fracture dislocations of other carpal bones, metacarpals, or phalanges. For instance, there have been documented cases of simultaneous coronal fractures involving both the capitate and hamate, or complex divergent fracture dislocations of the wrist. These more extensive injuries naturally complicate both diagnosis and management significantly.
So it can be part of a much bigger wrist injury picture.
Absolutely. In the long term, if these injuries are not addressed adequately, potential complications include post-traumatic arthritis, particularly affecting the hamate metacarpal joints, a vascular necrosis, especially in the proximal pole for body fractures if the blood supply is cut off, and residual instability of the 4th and/or 5th metacarpals, all of which can significantly impact a patient's long-term function and quality of life. So to distill that down, what's truly crucial here is that these secondary complications, such as tendon ruptures or chronic nerve compression, can often have a far more severe and debilitating functional impact than the initial hamate fracture itself. This reality powerfully reiterates the critical need for vigilance and, most importantly, early and accurate diagnosis to preempt these potential long-term issues. Missing this diagnosis has profound, often irreversible consequences for our patients.
That really underscores the urgency, doesn't it? Knowing the potential downstream effects of a misdiagnosis is perhaps the most important takeaway. This raises an important question. How do we best manage these injuries once diagnosed, distinguishing between conservative and surgical pathways, and critically considering the patient's individual needs, especially for athletes who are often keen for a rapid return to their sport?
That's precisely the challenge, and the optimal approach is indeed highly individualized, requiring a careful weighing of risks and benefits. For conservative treatment, the indications are primarily for undisplaced body fractures and, occasionally, for suitable acute, non-displaced hook fractures without comminution. The method typically involves immobilization with a cast or splint, such as an ulnar gutter splint or a short-arm cast, for a duration that can range from 6 to 12 weeks, with an average of about 11 weeks. This approach relies heavily on rest, limiting all aggravating activities, and may involve anti-inflammatory medications to manage discomfort.
11 weeks average immobilization is a long time, especially for an athlete.
It's a very long time. And the outcomes with conservative treatment for hook fractures carry that notoriously high rate of non-union, approximately 40–50%. While some patients may, interestingly, remain pain-free despite a radiological non-union, this extended immobilization period and the significant risk of non-union may be completely unacceptable for athletes or individuals in demanding occupations, where a rapid, predictable return to high-level function is paramount. Imagine telling a professional golfer they might be out for 3 months, only to find the bone hasn't healed anyway. It's also worth mentioning that emerging therapies, like low-intensity pulsed ultrasound, have shown success in isolated cases of hook non-union, offering a glimmer of hope, but more robust research is certainly needed to establish their broader efficacy and integrate them into standard practice.
So, if conservative management carries such a high risk of non-union, especially for the hook, when do we pivot to surgical intervention? What are the general triggers for that decision?
Good question. Moving to surgical intervention, the general indications are quite clear. Displaced fractures where the fragments aren't aligned, any symptomatic non-union, persistent ulnar or median nerve compression due to the fracture, ulnar artery compression, flexor tendon rupture, which is often a consequence of chronic non-union, metacarpal subluxation, and critically in athletes who require a rapid and reliable return to play. For these individuals, the faster, more definitive solution often tips the scales towards surgery.
Right, getting them back reliably is key.
Absolutely. For hook fractures specifically, excision of the hook fragment is widely considered the gold standard, particularly for symptomatic chronic non-unions, where pain and functional impairment persist, and often for acute displaced hook fractures, especially in athletes. The rationale is quite compelling. It leads to a much faster recovery as there's no waiting for bone healing. You're effectively removing the problem. The technique typically involves a modified volar wrist incision. Crucial steps during surgery include clear identification and meticulous protection of the ulnar neurovascular bundle, particularly the deep motor branch of the ulnar nerve, and all the contents of the carpal tunnel. The fragment is removed superiostele, which means you peel it off its bone covering to minimize nerve risk. Importantly, any remaining bony edges are carefully smoothed down to prevent ongoing tendon irritation or nerve impingement post-surgery.
So you're taking out the source of the pain and potential future irritation.
Precisely. Outcomes after excision are consistently satisfactory, with many studies reporting a rapid return to activity. For athletes, the median return to play is often around 6 weeks post-surgery, though the range can be wide, from as quick as 1 week to as long as 36 weeks, depending on the individual, their sport, and any complications. Clinical series have reported high rates of full recovery, sometimes as high as 97%. However, it's also important for us to acknowledge potential complications. Some research has found a higher incidence of complications than previously thought, around 25% in large cohorts, predominantly transient ulnar nerve dysfunction, scar pain, and wound issues.
25% is not insignificant, though.
It's not. While these are often transient neuropraxias, meaning temporary nerve irritation, they do occur and need to be discussed with patients. Furthermore, biomechanical studies have shown that hook excision can result in small shifts in the position of the little finger profundus tendon and a slight decrease in flexor tendon force, suggesting a potential, albeit often minor, compromise of power grip strength. Patients may also report minor complaints such as wound discomfort, slight weakness of grip, or altered sensation, but these are generally well tolerated.
That's a thorough breakdown of excision. What about open reduction and internal fixation, or RF? What's the thinking behind trying to preserve the hook, and when might that be a more suitable option?
The alternative surgical option for hook fractures is open reduction and internal fixation, or ORFF. This is favored by some surgeons to preserve the Hamate hook and restore normal anatomy. The theoretical advantages here are quite appealing. By maintaining the attachments of the transverse carpal ligament, the pisohamate ligament, and the hypothenar muscles, you are, in theory, preserving the native biomechanics, thereby potentially improving or maintaining grip strength.
Right, trying to keep everything as normal as possible.
Exactly. The technique typically uses small fragment headless compression screws or Kirschner wires. It's absolutely critical that any screws used are countersunk flush with the bone to prevent nerve irritation, particularly of the ulnar nerve. Crucially, the vascularity of the tip fragment must be confirmed, for instance, via MRI before fixation is even attempted, as an avascular fragment would simply not heal, and avascularity would contraindicate this approach. Small case series have indeed shown nearly 100% union rates with ORF. However, clinical evidence does not consistently demonstrate superior functional outcomes compared to excision in the long term, with some studies noting similar overall results to excision and even some instances of fixation failures or hardware-related issues requiring removal. This approach also requires a period of post-operative immobilization, typically around 3 weeks, before therapy can begin, which can be a drawback for athletes.
So, potentially good union rates, but maybe not a clear functional advantage over excision and a slightly slower start to rehab.
That's a fair summary. For body fractures, the management is somewhat more straightforward than for the hook. Non-displaced body fractures are generally treated conservatively with immobilization in a cast for approximately 6 weeks. Displaced body fractures, however, typically require open reduction and internal fixation using various implants such as Kirschner wires, grid plates, or headless compression screws to restore anatomical alignment and stability. So, to offer a nuanced view, while excision remains a definitive treatment allowing for a faster return to activity, often preferred for its predictability, ORAF may be considered for specific scenarios such as stress fractures or painful partial unions where fragment vascularity is confirmed. Here, one is carefully weighing the theoretical biomechanical advantages of preserving the hook against the procedural risks, the potential for hardware complications, and the need for postoperative immobilization. It's a delicate balance and a shared decision with the patient.
Prognosis and rehabilitation are always at the forefront of patient discussions, particularly for individuals eager to regain full function. What does the evidence tell us regarding recovery pathways, and how can the interprofessional team truly optimize outcomes for patients with hamate fractures, ensuring they get back to their prior level of function, whether in daily life or high-level sport?
That's a vital question, because managing expectations and providing a clear path to recovery is as important as the surgical or conservative treatment itself. The prognosis for hamate fractures is indeed a key discussion point with patients, and it varies significantly based on the treatment path chosen and the nature of the injury. For undisplaced fractures treated conservatively, bony healing typically occurs within 6 to 8 weeks, but it's absolutely crucial to counsel patients on the high non-union rate for hook fractures, which, as we've discussed, can be as high as 50%. This inherent risk needs to be part of the initial conversation.
So managing expectations right from the start.
Absolutely critical. Surgical treatment, particularly excision of the hook fragment, generally allows for a more rapid and predictable return to daily activities and sports. For athletes, the median return to sport is often quite impressive, typically around 6 weeks post-surgery. However, it's not uniform for everyone. A subgroup, about 14% in one study, may experience a delayed return to play, sometimes 12 weeks or more, and continue to report some level of discomfort. It's also well documented that delayed diagnosis or chronic presentation of the injury often correlates with a longer interval to surgery and, regrettably, a higher incidence of postoperative complications. So, the quicker we get to the root of the problem, the better the overall prognosis tends to be.
And rehabilitation, then, must be a cornerstone of that recovery, mustn't it? When does it typically begin, and what are the critical phases?
Without question, rehabilitation is a mandatory component of the recovery pathway. It is absolutely essential for restoring function and minimizing long-term complications. The timing of initiating therapy varies depending on the treatment. For conservative treatment, occupational therapy typically begins once the cast or splint is removed, allowing for gradual mobilization. For patients who undergo ORIF, therapy usually commences after a 3-week immobilization period to allow initial fracture stability. For hook excisions, rehabilitation can start much earlier, often as soon as wound healing is sufficient, generally within 3 to 4 weeks, because there's no waiting for bone union.
Okay, so excision allows for that earlier start.
Generally, yes. A typical rehabilitation protocol usually lasts between 4 to 6 weeks. It involves a carefully structured progression, starting with gentle, passive movements to restore range of motion, then moving into active exercises, and finally incorporating progressive resistance exercises to enhance strength, flexibility, and coordination. Functional movement exercises are also integrated at the later stages to help patients regain skills necessary for daily activities and, crucially, for their specific sports or occupations. For high-level athletes, returning to their pre-injury performance levels might take up to 6 months, and this can be significantly influenced by the intensity and demands of their specific sport, as well as their individual healing capacity and commitment to the program.
6 months potentially for full return to elite performance. That's important for athletes to know.
It is. In terms of deterrence and patient education, it's vital to counsel patients about the potential for chronic pain and, in the very long term, post-traumatic osteoarthritis, especially if joint surfaces were involved or if there was a delayed union. Emphasizing smoking cessation is paramount, as smoking can significantly delay or even prevent fracture healing. For athletes, promoting proper technique, ensuring equipment is correctly fitted, and engaging in appropriate strengthening and flexibility exercises are all key for injury prevention. Post-injury, advising on activity modifications such as avoiding heavy lifting, strenuous gripping activities, or returning to contact sports without explicit medical approval is vital to prevent recurrence or re-injury. What's truly fascinating here, and something that perhaps isn't emphasized enough, is how the management of these relatively rare injuries truly underscores the immense value of an interprofessional approach. This isn't just about the surgeon or the GP. It's a team effort from start to finish.
That's a brilliant point. How does that collaborative model truly enhance outcomes, especially for a complex case like a hamate fracture that has such subtle presentations and potential complications?
To optimize healthcare team outcomes, diagnostic collaboration is paramount. General practitioners, nurse practitioners, and physician associates must maintain an incredibly high index of suspicion due to the well-known high misdiagnosis rate of these fractures. They are often the first point of contact, and their astute clinical suspicion is what triggers the correct diagnostic pathway.
So the primary care team has a huge role in just catching it early.
A massive role. Radiologists then play a crucial, almost detective-like role, providing specific, often non-standard views, like the carpal tunnel view or performing detailed CT or MRI scans, to definitively confirm the diagnosis. Without their expertise in image acquisition and interpretation, we'd be lost. The orthopedic surgeons then guide the specific treatment plans, tailoring them based on the precise fracture type, its severity, and crucially, the patient's individual goals and lifestyle demands. Beyond diagnosis and surgical intervention, a holistic approach to patient support is absolutely essential. Nursing staff are vital for comprehensive preoperative preparation, educating the patient on what to expect, and then providing meticulous postoperative care, includes wound management and pain assessment. Pharmacists contribute significantly to pain management, ensuring optimal pharmaceutical therapy while advising on potential interactions with other medications an athlete might be on, or managing the transition from acute to chronic pain medication. And finally, physical and occupational therapists are indispensable. They are the ones guiding the intensive rehabilitation, meticulously reporting progress to the entire team, and educating patients on optimal body mechanics and ergonomics to prevent re-injury and facilitate a safe return to activity.
It really sounds like a well-oiled machine is needed.
It is. This collaborative model ensures that all aspects of patient care are addressed, ultimately leading to optimal patient outcomes, particularly for high-demand individuals like athletes, enabling them to return to their prior functional levels and perform without limitations. It's a true symphony of expertise.
So what does this all mean for you as a medical professional navigating the often complex landscape of hand and wrist injuries? We've seen that hamate fractures, while perhaps uncommon in your daily caseload, carry truly significant implications, particularly for active individuals and athletes. Accurate and timely diagnosis, often reliant on moving beyond standard X-rays to advanced imaging like CT and MRI, is paramount to preventing debilitating complications like chronic non-union, or worse, devastating flexor tendon ruptures that can permanently impair hand function. The choice of treatment, be it conservative immobilization with its inherent risks, or surgical intervention like excision for a quicker return to play, or even ORIFIF in specific cases, is a nuanced decision. It's heavily influenced by the fracture's characteristics, its potential for complications, and critically, the patient's individual goals for recovery and their desired return to activity. This deep dive has hopefully underscored the vital importance of a holistic, interprofessional approach, ensuring every member of the healthcare team plays their pivotal part in guiding the patient back to optimal function. As medical professionals, understanding these subtle presentations and the evolving evidence behind management strategies for less common injuries like these allows us to truly enhance patient care and facilitate the best possible return to function. How might this nuanced understanding influence your next clinical assessment of that persistent ulnar-sided wrist pain? Perhaps it's not just a sprain after all. If you found this deep dive valuable, please do consider rating and sharing the show with your colleagues. It truly helps us bring more in-depth discussions like this to you.
Indeed. Continuous learning and fostering a truly collaborative mindset are, in my view, the cornerstones of excellent orthopedic practice, ensuring we leave no stone unturned in our pursuit of optimal patient recovery and function.